It's great to be here today. I title my presentation as "Do I have a bad blood?" This is a common question I always encounter when I see a patient with myelodysplastic or acute myeloid leukemia or a precursor condition called clonal hematopoiesis of indeterminate potential. We have a clinic at Vanderbilt Cancer Center where we see a precursor condition called CHIP as well, where we are trying to understand how we can prevent development of myelodysplastic syndrome or acute myeloid leukemia in some of the patients. So today I'm going to focus my discussion mostly on the precursor condition as well as a myelodysplastic syndrome, which is the chip can progress into myelodysplastic syndrome. And I will talk about some of the treatment options in myelodysplastic syndrome. Okay. These are my disclosures. I work very closely with pharma companies in developing some of the drugs. Along with that, I also co-host a podcast called Blood Cancer Talks, where we talk about everything related to blood cancer drug development and new treatments available, as well as some of the nuances in treating patients with blood cancers. So to start with, I will talk about clonal hematopoiesis, what it is, and how it is defined, as well as what it means for a patient. So clonal hematopoiesis, it is defined as the expansion of a mutant, somatic mutant, in the blood stem cells. So I want you to think of it as like a typo in your blood stem cells, and that typo over the period of time expands into expands into a clone, and that can potentially have downstream consequences. It is a natural part of aging, because as we age, we tend to make our blood stem cells tend to make mistakes, and that can propagate into development of a disease. So this was first described back in 2014. A series of publications that were published described this entity, and it as you can see in the slide here, it's reported in about 1% in the patients who are at 60 years of age, and with age it goes up as well. The prevalence 10%, 70, and 30% in more than 90. So it's quite common, but there is a clear-cut definition that emerged after this initial publications that were came out, and the clear-cut definition now it is called as clonal hematopoiesis of indeterminate potential, and they put the threshold of this mutation at 2%, means roughly 4% of your blood stem cells, if they have a particular mutation, and then that is called as clonal hematopoiesis of indeterminate potential. So these are the mutations which are normally seen in patients with myelodysplastic syndrome. We are able to detect this much earlier, before they develop any kind of cytopenias. And these are the common mutations we also seen in myelodysplastic syndrome as well as acute myeloid leukemia. So what it means? So this entity, the clonal hematopoiesis of indeterminate potential, prevalence increases with age. What we have seen is that patients with who have this mutation, who do not have any kind of blood count abnormalities, can still have a worse prognosis. In other words, they can have increased mortality from other conditions as well, and that is something that has emerged after this initial literature was published back in 2014. As you can clearly see that in patients who are older than 70, if they have a mutation, they have worse prognosis compared to patients who do not have this mutation. And what was one of the main reason which surprised a lot of us, that chip not only increases the risk of blood cancer, but can also increase the risk of cardiovascular mortality, which was a big surprise. And right now, at Vanderbilt, we work very closely with our cardiologists in accurately risk stratifying patients with these mutations when they present to our clinic, to see how we can address the other modifiable risk factors for cardiovascular disease, such as high blood pressure, diabetes, or cholesterol, so that we can potentially mitigate some of the risks that develops because of the presence of these somatic mutations. And along with the development of the cardiovascular risk, there is a risk of blood cancers as well. It is not huge, as you can see in the slide here. And in the big studies that were published, the risk is very minimal, about 1 to 10%, based on various risk factors, are at risk of progressing into blood cancers. And to accurately risk stratify, there is a scoring system right now that has been developed. And this is something we routinely employ in our clinic when we see a patient with this somatic mutation present to the clinic. We look at all these various variables, age being one of the factor as well, and then we look at the other predictor variables, such as the presence of DNMT3 mutation or high risk mutation, and the number of mutation also is very important, along with what fraction of the stem cells in the bone marrow have this mutation is also equally important, along with the what kind of blood count abnormalities they have. With all these variables, we are able to accurately risk stratify the patients into high risk, intermediate risk, and low risk. These risk means that these are at risk of progressing into a blood cancer.